The key to a pathophysiological understanding of nystagmus is to understand the concept of plane and axis and the coordinate planes in which they exist. Now, what exactly do I mean by a plane? When this eye makes this movement, it is supposed to be moving like this in this plane. So this is, you can consider this as a horizontal plane. So this is moving in the horizontal plane like this. The axis of rotation is this. You can see this. Okay, so it is rotating around this axis, and the axis of rotation is always perpendicular to the plane of the nystagmus. So in this case, if you consider this as horizontal plane, you see that the axis is perpendicular to the horizontal plane and the eye is oscillating around this vertical axis in a horizontal plane. When it comes to vertical nystagmus, if the eye is moving in a vertical plane like this, means it is moving like this in the vertical plane. So the plane is vertically oriented and the axis is going to be horizontally oriented, right perpendicular to this vertical plane, and the nystagmus, the eye oscillates in this plane. So eye is supposed to be oscillating in a vertical plane and the axis is in the horizontal plane, and the axis is horizontally oriented. Okay. Now when it comes to torsional nystagmus, so what happens when it comes to a pure torsional nystagmus? So when you see a torsional nystagmus, the eye moves in this fashion. So here what exactly is happening is it is rotating in this fashion. So the plane is like this. Okay, the plane is like this. For horizontal, the plane was like this. For vertical, the plane was like this. Okay, this is almost a sagittal or a parasagittal depending on where you place it, and this is coronal. So we have the plane which is coronal, and the axis, you see this axis is perpendicular to that coronal plane, and the eye oscillates around that axis in the coronal plane. That is the torsional nystagmus. Having defined the plane and the axis, now we need to define the coordinate plane. Like when we say that this nystagmus is in the horizontal plane, what do we mean by horizontal? Is it in relation to the earth horizontal, that this is horizontal and this is vertical? Do we talk in terms of the earth horizontal, or do we talk in terms of the head, where okay, for the head this is the horizontal plane? Okay, in the sense like we know that the semicircular canals have a 30-degree orientation upwards, so this is the horizontal canal plane. So are we talking about a axis that is oriented along the lateral semicircular canals or the horizontal semicircular canals, or are we talking about something that is oriented along the earth horizontal, or are we talking about something that is oriented along the eyeball horizontal? Okay, pathophysiologically each of these things make different meaning, and when we actually decipher or a nystagmus based on which axis, the axis in terms of which coordinate plane that axis exists, then the understanding of nystagmus and the deduction of the pathology causing that particular kind of nystagmus becomes very, very clear. For example, what happens in congenital nystagmus is, okay, all of us know that congenital nystagmus is associated with generally a horizontal nystagmus is a very common way in which a congenital nystagmus presents. So basically the eye is oscillating in this plane. So in this plane. So what happens is the plane, we consider it as horizontal and the eye is oscillating in this horizontal plane. The one characteristic feature of the congenital nystagmus is that this horizontal is not fixed to the earth horizon, it is not fixed to the head horizon or the semicircular canal for that. No, it is fixed to the horizontal with respect to the eyeball. So when the person looks up, the plane of the nystagmus also turns with the eye. So along with the eye, the plane also turns. So what happens is the axis also rotates with the plane. So what happens is when you see the person looking straight ahead, you see the nystagmus something like this. When the person looks up, the axis also has tilted. You can see that the axis also has tilted and the nystagmus rotates. So when you actually look from the pupil side, when you look onto the pupil, you look whichever position you see, from directly straight ahead or when it is looking up, you look straight into the pupil, you always see that the pupil is moving horizontally. There is no torsional component imposed. What happens when we talk about a nystagmus, not the congenital nystagmus in which the plane moves with the, in congenital nystagmus the plane moves with the eyeball. What if this plane, instead of being fixed to the eyeball, is fixed to the head? Okay, that is what we see in people afflicted with the horizontal canal BPPV. We notice in a person with horizontal canal benign paroxysmal positional vertigo that though there is a predominant horizontal nystagmus, we notice a small amount of torsional nystagmus. What is the explanation? Where does that come from? It comes from the fact that this plane, in case of a lateral canal BPPV, instead of being fixed to the eyeball, this plane is actually fixed to the head, and it is fixed to the head along the plane of the lateral canals. Okay, so what exactly happens if this plane, instead of being fixed to the eye and rotates with the eye when it comes up and down, the plane remains fixed at an orientation of around 30 degrees from the earth horizontal or in the neutral position of the head, and it keeps moving with the head. But let us not go into that details right now. We'll look at a person who is looking straight ahead. Okay, so if the plane was fixed like this, so what would happen? That I will show you in a small demonstration. So what I have here is out of a container, I have just made something that looks like an orbit. So this you can consider as the orbit. So if this is my orbit and this is the eyeball situated within the orbit. So what happens in a person with a horizontal canal benign paroxysmal positional vertigo? We know by Ewald's law that pure horizontal canal stimulation moves the eye in the plane of the horizontal canals or the lateral canal. So if the plane is this one, so if this plane is like this, if the plane is oriented in this direction, the axis will be oriented just perpendicular to that. So what exactly I have made here is I placed the axis perpendicular to the plane, I have exaggerated that angle by a little bit more than 30 degrees just for the sake of demonstration. So what happens is, now this eyeball, okay, is this orbit is facing forwards, but because the horizontal canals are oriented almost in this plane, now what happens here is I have selected the axis which is vertical to the plane of the horizontal canal. So because the axis is vertical in relation to the horizontal canal, now what you see is the eyeball, irrespective of where it sees, the orientation or the rotation is around this axis, okay, and not the vertical with relation to the eyeball itself, because this is fixed to the head, this axis is fixed to the head. So what happens when the person is actually looking straight ahead is that, I will just make this moment, okay, is that, can you see a small torsional component? You can see a predominant nystagmus in the horizontal plane. However, that is horizontal plane because the axis is almost vertical, but it is not completely vertical. It is oriented perpendicular to the plane of the horizontal canals. Okay, so it has a tilt. So when you look at this, you can see that the eyeball shows a torsional component, because you or all of us are used to looking at the eye from the straight ahead or the pupil perspective, and not exactly from the perspective of this axis. So when you look at the from the pupil perspective, nystagmus that is oriented along the plane of the lateral canals actually shows a small torsional component, and that is the explanation, and that is the reason why we see a torsional component in most of our people with horizontal canal benign paroxysmal positional vertigo. So when is the time when this torsional component becomes reduced? It becomes reduced when the eyeball itself looks when the eye itself looks upwards, where the pupil starts becoming oriented more horizontally or more perpendicularly in relation to this particular plane. When somebody looks a little up, then it will become a little more horizontal, and as the person looks down and down, it becomes more and more torsional. And even when the person looks almost straight ahead, even then you can see that there is going to be a torsional component. Okay, now what I have done is I have just made the eye look a little bit upwards compared to the just now completed previous demo. So what now you can see that when the pupil in the previous video, the pupil was a little bit more down. Now I made it go a little bit upwards, and even then you can see that there is a torsional component. If you these spokes that I have drawn are to show the scleral blood vessels, exaggerated representation of scleral blood vessels, to make the torsional component more obvious. And only when the eye moves even more upwards, okay, even more upwards, is the time when this torsional component will become less. What happens in case of posterior canal benign paroxysmal positional vertigo? So just imagine it is any of the vertical canals. Okay, so we are talking about the right posterior canal. So when you talk about the right posterior canal, the plane of the canal is the LARP plane, that is the left. Okay, I'm stretching my hand forward and to my left. So left anterior and right posterior. So this is the plane. So this is the plane. So this is front and towards my left, and this is back and towards my right. So this is the LARP plane. So the expected axis of rotation of the eye is along this plane. So it is going to be along this plane. So what you expect here is, I will just show you the same thing. Okay, now what happens is, so we are speaking about an axis which is a plane which is oriented in this plane. Okay, in LARP, left anterior and right posterior. So the axis will be almost, if this is the plane of movement, the axis will be just perpendicular to that plane. So the axis will be something like this. Okay, so axis will be something like this. I will show you. So the axis is something like this. So this is the front and this is the back. So what exactly happens when the axis is like this is, again we know that here the axis is important and not where the eyeball is looking to determine the oscillation of the eye. So when you actually look at the pupil of a person who is looking almost straight ahead, but if it is oscillating along this axis, what happens is you see a vertical and a torsional nystagmus. Vertical and a torsional nystagmus. If the person were to look instead of straight ahead or towards the right, instead of that, if the person were to look to the left, what exactly happens is the pupil becomes almost oriented in a vertical plane with respect to this axis, and that is the time when we actually see a pure, that is the time we will see a pure vertical nystagmus. And when the person looks fully towards this side, towards the right, then it will be more torsional. And if the person is looking almost straight ahead, you will see a vertical torsional nystagmus like how you see here. I will now change the orientation of this eyeball or the gaze of this eye to look more to the left. And the expectation is when the eye looks more, with this plane remaining fixed to the head, okay, with this plane remaining fixed to the head and not being fixed to the eyeball, when this looks to the left, the eye should move, should appear to be moving more in a vertical axis. Does that happen? Let us see. So what I have now done is, okay, made the eyeball look more towards the left, okay, which means it is more now oriented in the LARP plane. So if it is oriented in the LARP plane, it is almost completely vertical to this particular axis. So if it is vertical to the axis, now if you look at the eyeball oscillation, it looks almost vertical. You don't notice the whatever scleral blood vessels torsionally moving. That doesn't happen, okay, unlike how it happened on the previous occasion when the eyeball was looking more straight ahead, where there was a vertical component and there was a torsional component. To summarize, the key to a pathophysiological understanding of nystagmus is to understand the planes and the axis. In addition to understanding the planes and axis, in which coordinate plane does that particular plane or the axis happen? In cases of congenital nystagmus, the coordinate plane is the plane of the eyeball. So what happens in congenital nystagmus is that as the eyeball moves up and down, the plane also moves up and down. As the eyeball moves up and down, the plane also moves. So horizontal nystagmus looks horizontal irrespective of the gaze position, whether the person is looking up or looking down, because the coordinate plane is fixed to the eyeball and it moves with the eyeball. When it comes to the vestibular, especially semicircular canal generated nystagmus, this particular plane is not fixed to the eye, it is fixed to the head. For example, in the lateral canal, this is fixed to the head just along the plane of the horizontal canal, which are oriented around 30 degrees from the horizontal, lifted upwards, friends, lifted upwards. So along this orientation, this plane remains fixed. Now, when this plane remains fixed, as the eyeball orients in different planes, it appears to take a different kind of nystagmus. Okay, in some directions it looks like there is a more torsional component, especially when there is a horizontal canal BPPV, and when you look at more up and up, it looks having only a pure horizontal component. Okay, so that has nothing to do with the plane actually changing. It is actually something to do with the coordinate plane now being fixed to the head. So when we actually start describing nystagmus in terms of its coordinate planes and with respect to that coordinate plane, which plane that particular nystagmus is oscillating in, then it becomes very, very straightforward to reach a diagnosis. Congenital nystagmus coordinate plane is fixed to the eyeball, and the semicircular canal generated nystagmus is fixed to the head, because semicircular canals are fixed in the head. As the eye moves up and down, the nystagmus appears to have bigger or lesser torsional components, and appears to it is just an apparent change in the plane, because we are trying to reference it with the eye. If you shift the reference instead of from the eye to the head, then the appearance of torsional in some directions and vertical in some other directions just becomes plain. And that is the key to a pathophysiological understanding of nystagmus.